Simon Burns.
Thank you, Madam Deputy Speaker. I'd like to begin by congratulating my honourable friend on securing what is a very important debate for him and his constituents, and to commend him for the commitment that he has shown, as illustrated during his high-powered speech this evening, in campaigning on health issues for his constituents to ensure that they get first-class quality care. I'd also like to take this opportunity to recognise the hard work and dedication shown by NHS staff in his constituency. Their dedication, expertise and drive do so much to improve the health and well-being of his and other honourable members' constituents on a daily basis. This government will support and empower them to provide his constituents with health outcomes that are consistently among the very best in the world. As part of our commitment to the NHS, we are consistently increasing the amount of money we provide to local organisations. Total revenue investment in the NHS in 2011-12 will grow to over £102 billion. Allocations announced on the 15th of December will provide PCTs with £89 billion to spend on the local frontline services that matter most, an overall increase of £2.6 billion or 3%. Of that, Hertfordshire PCT will receive £1.7 million, a cash increase of £47.7 million or 2.9%. Madam Deputy Speaker, before turning to the specific issue of the Cheshunt Urgent Care Centre, I'd like to set out the context of our plans to modernise the NHS and bring considerable improvements to the healthcare experience by my honourable friend's constituents. We believe that local NHS services should be centred around the patient, be led by local clinicians and be free from political interference, either from this House or from the various levels of NHS bureaucracy. To this purpose, we've set our proposals to liberate the NHS from central control. We will set frontline professionals free to innovate and make decisions based on their clinical judgment and the needs of their patients, with the sole aim of improving the quality of care given and outcomes achieved. Responsibility for budgets and commissioning care will transfer from managers within the PCTs to clinicians with general practice-led consortia. Patients will receive healthcare that is specifically tailored to their own communities and personal circumstances. Our plans will radically simplify the NHS. Two whole layers of management, the SHAs and the PCTs, will no longer be necessary. We anticipate a one-third reduction in overall administration costs, saving the NHS £5 billion by the next election and £1.7 billion in every year after that. Billions of pounds, of which every single penny will be reinvested into frontline services. There are now 177 Pathfind consortia across England, covering 35 million people, over two-thirds of the population. These consortia are taking a lead in rejuvenating local services, cutting out waste and putting the needs of patients before the needs of the system. There are now 3 Pathfinder consortia in place across Hertfordshire. The East and North Hertfordshire GP Commissioning Consortia covers part of my honourable friend's constituency. Clinical leadership will also go hand in hand with greater local democratic accountability. Under any willing provider, an increasing number of independent sector and social enterprise organisations will deliver NHS services. Unlike now, local authorities will have the power to scrutinise all providers of NHS-funded services. Local authorities will be able to require the provider to present information and appear at scrutiny meetings in order to hold them to account. Already, 134 local authorities, almost 90% of the total in England, have signed up to be Health and Wellbeing Board early implementers, including Hertfordshire County Council. The make-up of health and wellbeing boards will be left to their own discretion, but it will include representatives of GP consortia, directors of public health, adult and children's services, representatives from Health Watch and the NHS Commissioning Board, and locally elected councillors. As well as preparing a joint strategic needs assessment, they will need to draw up and deliver a strategy to deliver the requirements set out in that assessment. In short, health and wellbeing boards will promote integrated working across the NHS, public health and social care, and they will hold NHS services to account, leading to better, more accountable services for local people. The government is clear that in a patient-led NHS, any changes to services must begin and end with what patients and local communities want and need. Until the new system is in place, we expect PCTs to follow best practice in ensuring that local communities are fully engaged in such decisions. When it comes to urgent care, it is vital that local services are coherent and easily accessible around the clock. But again, we have been clear that decisions as to the form they take are best made locally in the light of local needs. Within the Broxbourne area, there are 12 GP surgeries, 4 of which are in Cheshunt itself. The area also has an out-of-hours GP service provided by Hearts Urgent Care based at the Cheshunt Community Hospital. The community hospital also provides outpatient clinics and a range of community services. There are 22 pharmacies in the borough, 9 of which are in Cheshunt, and 1 of which opens for extended hours. I would now like to turn to the specifics that my honourable friend raised regarding Cheshunt Urgent Care Centre. I understand that in 2007, the former 2 Hertfordshire PCTs, in partnership with the 2 Hertfordshire acute trusts, held public consultations on a health strategy, delivering quality healthcare for Hertfordshire. The health strategy in respect of urgent care aims to improve access to urgent care services within Hertfordshire so that people with urgent, non-life-threatening conditions can be redirected from hospital A&E departments to receive more appropriate treatment more quickly and closer to home. In response to the public consultation, the PCTs agreed to the piloting of urgent care centres at both Cheshunt and Hertford on the basis that they would be evaluated before longer-term decisions were made about their future. And I think it is crucial to remember that these were pilot schemes, and it was always understood that once the pilot schemes had completed a period of time so that experience could be gained, that they would be evaluated before longer-term decisions were made about their future. The urgent care centres were established as part of a 12-month pilot project between January and December 2010, with the specific objective of relieving pressure on local accident and emergency services. The prime purpose and objective was to reduce the number of patients seen by 20,000 per year by providing local people with direct access to urgent care centres. The purpose of the urgent care centres is to see and treat people with urgent but not life-threatening illnesses such as sprains, strains, broken bones and minor burns and scalds in a local community setting, allowing A&Es to concentrate on life-threatening emergencies. The PCT commissioned an independent research organisation, Opinion Research Services, to evaluate the success of the pilot centres at Cheshunt and at Hertford in the constituency of my honourable friend, the member for Hertford and Stortford. I understand that during the evaluation process, the views of the general public, NHS staff and local GPs were taken into account. Evidence was then submitted to an evaluation panel consisting of local GPs, local councillors, staff from local authorities and representatives from the PCT. When they met on the 17th of January this year, the evaluation panel came to the unanimous view that urgent care centres were not achieving their aim of diverting significant numbers of patients from A&E. And I'd just like to remind the House that that, of course, was the prime purpose of the pilot scheme when the pilot was started at the beginning of January 2010. Instead, considerable numbers of those using the urgent care service were seeking advice and treatment usually provided by GPs for conditions such as raised temperature, sore throat and headache. It was never the intention that the urgent care centre would have a primary care focus. They were established to relieve pressure on local accident and emergency services and to treat people with urgent but not life-threatening illnesses. The evaluation panel recommended that the pilot centres should not continue in their current format. Instead, they recommended that the PCT should reconsider recommissioning activity through 1 or 2 minor injuries units. The panel also recommended that the PCT consider how they can improve access to high-quality primary care to compensate for the loss of the urgent care centre. As my honourable friend is aware, Hertfordshire PCT published its board papers on this issue on the 18th of March. I understand the PCT met earlier today to consider these recommendations and has subsequently decided to uphold them and not recommission the urgent care centres in their current form. Instead, it will consider recommissioning a minor injuries unit at Cheshunt. I accept, as my honourable friend has made clear, that the Cheshunt Urgent Care Centre is well regarded by local people. However, the provision of services is a matter for the local NHS. As my honourable friend understands, it is not for ministers to interfere and micromanage the day-to-day business of the NHS. My honourable friend also mentioned in his speech the situation of access to GPs in the Cheshunt area. I would like to reiterate what my honourable friend said during the course of his comments, because the evaluation panel recommends that the PCT does consider how they can improve access to high-quality primary care to compensate for the loss of the Cheshunt Urgent Care Centre, and the PCT has upheld this recommendation. I understand, and my honourable friend did refer to it during the course of his remarks, that the PCT has in place a programme of measures to improve access to general practice, and I am sure that my honourable friend will agree with me that it is important that this is pursued and achieved. Very briefly, yes.
I would just argue that the PCT should have been improving the performance of GPs in my constituency for the past decade, and they've arrived a little late at the party.
I think my honourable friend makes an extremely valid point there, and it is only sad that it's only in the last few months that we have been able to come to grips with some of the failings of the previous government in making the local health service more accountable to the needs, the wishes and the requirements of local people. And he and I will be totally in agreement with that. And that is why I believe that the core of our health service modernisation programme, to put patients at the heart of the delivery of care, is so important, and why I'm so sure that my honourable friend will feel and agree with me that that is an appealing principle to work from. The PCT has established a funding initiative for GP practices, as my honourable friend said, to support the Improving Access programme, which includes funding for new telephone systems, improved appointments and check-in systems and medical equipment. The programme continues to be a key area of work for PCT staff, who will work closely with GPs to make sure it's implemented and that local people see improvements. I am advised, and I hope this reassures my honourable friend, that the latest GP patient survey results show that 4 GP surgeries in my honourable friend's constituency scored 91% or above in terms of satisfaction with care. 2 of these practices are in the Cheshunt area: the Cromwell Medical Centre, which achieved a 92% record, and the Warden Lodge Medical Practice that received a 93% rating. I say in conclusion that I am assured that the PCT will hold discussions with East and North Hertfordshire GP consortia and involve them fully as they conduct this further investigation. I am also assured the PCT will have conversations with the public and other stakeholders, including my honourable friend if he wishes, to gain further understanding of the needs of the local population and explain potential users of the services what a minor injuries unit can provide. In addition, I am also advised the PCT will strengthen its performance management of GP practices to address the problems some local people have had. I fully understand the concerns that my honourable friend has raised. However, the board has decided the PCT needs to further explore the possibilities of setting up a minor injuries unit and I understand the PCT will test the feasibility of the new unit with providers.
The question is,